I'll be talking about phakic intraocular lenses in this presentation. I'd like to thank the organizing committee of APSRS for giving this opportunity to talk about phakic intraocular lenses. I have no financial interest in any of the products mentioned. So what are phakic intraocular lenses? Essentially, they are contact lenses within the eye. The main advantage of phakic intraocular lenses is able to correct a larger range of refractive error. We can correct for myopia up to -23 diopters, for astigmatism up to 6 diopters, and we can even correct very high hyperopia. Phakic intraocular lenses are usually used in cases where LASIK or surface ablation is not suitable. For example, where the cornea is thin or the cornea is abnormal or suspicious. There are different types of phakic intraocular lenses, and they are classified based on the location. Anterior chamber, for example, previously the Alcon has a cachet lens. Iris fixated, where it's fixated onto the iris, like the AMO Veriflex lens, and the posterior chamber lenses, for example, the Star ICL. So depending on where it's located, in front, on the iris, or behind the iris. So the advantages and disadvantages of phakic intraocular lenses compared to corneal refractive laser surgery. The main advantage, as I mentioned, is the wide treatment range. Secondly, we are not removing or ablating any corneal tissue. So in a way, it's removable because we can reverse this by removing the ICL or the phakic intraocular lenses. In some conditions whereby the degrees or the myopia is very high, it can give superior vision compared to LASIK, and the results are generally good and very effective and safe. The main disadvantage is usually the cost. It's a lot more expensive compared to a corneal laser refractive surgery. Usually it's about 3 to 4 times the cost of a LASIK or surface ablation. It is also an intraocular surgery with its risks. And because it's intraocular surgery, the potential complications can be more severe. For example, infection, cataracts, corneal decompensation, and raised intraocular pressure. The first phakic intraocular lenses were angle supported, or ACE-IOLs. However, due to complications like endothelial cell loss, corneal decompensation, pupil ovalization, most of the anterior chamber lenses have been withdrawn due to complications. Iris fixated lenses, there are different types. Basically, these lenses are attached to the iris. They give good outcomes, but they can still result in endothelial cell loss and pupil ovalization. This is some of the photos showing on the left side anterior chamber phakic intraocular lenses, the right side iris fixated lenses, other types of anterior chamber lenses you can see. So because of problems with the anterior chamber lenses, basically the problem of loss of endothelial cell count with time and corneal decompensation, right now, more and more ophthalmologists are using posterior chamber lenses. There's lower incidence of halos and glares, there's lower risk to the endothelium. However, because of its proximity to the cataract, there is a higher risk of cataract formation and pigment dispersion. The current common models that are being used are the Star ICL, uses a special material, a Collamer soft material, the IPCL, or the implantable phakic contact lens by Spectrum UK. I'll talk about the ICL as this is the lens which I commonly use and is probably more common or popular in Southeast Asia. You can see the lens is very thin, it's only about 100 microns. Okay, in the older versions, where there is no aqueous flow within the lens itself, there's a need to create a peripheral iridotomy. You can see from the picture in A. Okay, this is how the lens look like. Okay, if you select examination of the lens, if you look just using a wide view, you may not see the lens itself. You need to cast a slit beam. You can see the lens just anterior to the. You can see a lens anterior to the natural lens. There's a space between the ICL and the natural lens, which is what we call the ICL vault. This is how it looks like on ASOCT. Okay, the newer version has a hole in the center. This allows the flow of aqueous from the posterior to the front. This reduces the risk of pupil block and therefore eliminates the need for a peripheral iridotomy. So this is how a surgery is performed to implant the ICL. First we create a side port and inflate the anterior chamber, and after that we create another side port on the other side to allow manipulation. Okay. After that we create the main wound. Okay. Making sure that the anterior chamber is fully inflated with viscoelastic before injecting the ICL lens. We have to take care not to damage the cornea and the natural lens of this patient. So once the ICL is inside, we use a ICL manipulator to position the foot plate behind the iris. After that, we adjust the position of the lens according to the astigmatic marking. Okay. So you can see this. Okay, make sure that it's in the correct alignment. And once the alignment is correct, we will close the wound. We just hydrate, it's sutureless. Just hydrate the wound and remove the viscoelastic material, and that's the end of the surgery. Okay, so what's the pre-op evaluation for phakic intraocular lens? It's the same as any LASIK procedure. We will do a manifest and cyclorefraction. We will check the visual acuity. We will measure the size of pupil, do a GAT, check the anterior depth. The most important for this, for phakic intraocular lenses, is actually the anterior chamber depth. We do a corneal topography, pachymetry, endothelial cell count. So there is a certain endothelial anterior chamber depth requirement. Usually, the minimum requirement recommended is about 3 millimeters. So an op scan is done, or topography is done to provide several measurements. We need the anterior chamber depth, we need the pachymetry, the K readings, and these are provided to the manufacturers, who will then calculate the lens power and the size that is required. I normally do a ultrasound biomicroscopy to UBM to make sure the sulcus measurement is appropriate, and also to make sure there's no iris cyst. So like in this case, you can see there's an iris cyst at the angle, and that will prevent the lens from sitting properly, and this is one of the relative contraindication to ICL surgery. The outcomes are good, however, for the angle supported, there's a loss of endothelial cell count and therefore is no longer being used nowadays. Iris fixated has longer follow-up, good predictability, however it does cause pupil ovalization and requires a larger wound. And currently, posterior chamber lenses are more popular because they have good safety efficacy with lower complication rate. So currently, due to the long-term complications of angle fixated and iris fixated phakic intraocular lenses, the main phakic intraocular lens used are the posterior chamber lenses, and the STAR ICL is the most commonly used phakic intraocular lenses now. However, these lenses do have potential risks of complications. The older versions, there's risk of pupil block, sudden rise in intraocular pressure. Sometimes the sizing can be an issue. If the sizing is either too small or too big, we may have to change the lens to the correct sizing. Some patients still do get problems with optical quality, night vision symptoms. There is an initial loss of endothelial cell count, but usually it stabilizes over the long term. Sometimes they can get patients do get a bit of inflammation. There's always a risk of lens decentration or rotation, and over the long term, there's always a risk of anterior subcapsular cataract and glaucoma. So this shows in some cases where the lens is very near the natural lens, it can give rise to early cataract. Give you a case study of one patient where he had toric implantable lens for a very high degree of astigmatism. He was well 6 weeks after surgery with good unaided vision. Okay, I can see the refraction was very good, was plano in both eyes. But he returned 4 months later with a sudden drop in left visual acuity, and his refraction was as follows. The left eye you can see is plus 1.5 with an astig of minus 4. And you can see that the lens has rotated from its normal 180 degrees position. So in this case, we have to perform ICL rotation surgery. So the good thing is that lens is, well, the good and bad thing, the lens is not fixed, so we can rotate it back to its normal position. Okay, but because it's not fixed, there's always also a tendency for it to rotate if there's a sudden hard impact on the eye. So sometimes as optometrists, you may see this in your practice where the patient suddenly comes with a sudden change in his cause. However, because of its controversial because of its risk of complications. However, I think it's important to understand for phakic intraocular lenses, long-term follow-up is required compared to LASIK. Thank you very much.
Dr. Jean Chai.
I would like to.
Yeah. She will speak on ocular surface disease in cataract and refractive surgery. Okay, Dr. Jean Chai, please.
I would like to thank the organizing committee for inviting me to speak at this symposium. Today, I'll be talking about ocular surface disease in cataract and refractive surgery. I have in cataract and will be happy to take any questions if you have them. I can also be reached at the following email. Thank you very much for your attention today.
Okay. Wait. Okay, so the chairperson, right, when he's here, he sees himself as green, right?
Chairperson,
Yeah.
yes.
Yeah.
But by right, he's supposed to turn off his camera lah. Then less confusion lah.
Ah, okay.
Yeah, turn off the camera, then yeah, he only see the superimpose everything.
Ah, okay, good,
Yeah.
better. Yeah. Okay, next speaker, Dr. Daniel Chua. Please. Dr. Daniel Chua, please.
Good morning, everyone, and thanks for the opportunity to speak at this session. I will be covering on the factors that are considered in the use of toric intraocular lenses or IOLs in cataract surgery and the outcomes of using such IOLs or rotation of the IOL. That is all from me, and thanks for your attention. These are some of my references. And thanks again.
That's it? You fast forward Daniel Chua's one, right? Yeah. Okay, good. Okay, we have come to the end of the talks. We shall have a Q&A now. Okay, what happens now during Q&A?
Okay, so for Q&A, I recommend in those sessions that saying we are going to Q&A now, we will take in questions, or we immediately show gallery view.
Show gallery view already. Gallery view. Okay. Can we ask everybody to turn on the camera, please? Don't be shy.
So during gallery view, do you want them to post the instruction or the moderator say it out?
What sort of
Like turn on your camera
Yeah.
in case it's audit lah. So
Yeah.
so basically, if anyone off the camera, then we tell them to turn on.
Yeah.
But if everyone on, so you want everyone to be unmute or only the one who is speaking?
only the one that is moving. So basically, right, when we are about to go into coming up is the panel discussion. So please remember to turn on your camera when the session starts. Is that convert them to off camera throughout, right? Yeah. So should I just say please turn on your camera at all times?
So you got see anything from chat?
Hello. 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 Hold on.
Huh?
Hold on, hang on. People are asking me things. Eh? I come at tomorrow, no, right?
Yes, tomorrow.
Yes.
Yes, hi, here. Yeah. Yes. Ah. Yes, on Saturday. Yeah, he need to log in. Correct.